working session. All right. This is a working session. All right. Okay. So once again, we are back to the what? To the midbrain. Okay. Very important. The brain is like the neck. Okay. So a lot of things are going to converge in the what? The midbrain. A lot of things that are ascending and a lot of things that are descending. All right. So we see the what? The aqueduct of Sylvius. All right. And around that, where's the Taylor? There we see the what? The periaqueductal grade. And who do we say we find in the lateral aspect of the periaqueductal grade? Who's in the lateral aspect? Who's in the lateral aspect, we said, of the periaqueductal grade? Yes. And you're seeing well, Dr. Roxanne?
Yes, I'm seeing.
Okay. So the mesencephalic nucleus of the trigeminal nerve. So that's very important. Reasonable? All right. The spinal nucleus of the trigeminal nerve, very important. Then we see what? The substantia nigra. Okay, just relax. Just relax. Then we see the substantia nigra. All right. Then the very prominent what? Red nucleus at the level of the what? The superior colliculus. At the level of the inferior colliculus, what would we be seeing? The decussation of the superior cerebellar pedunculus. Alright? Very good. So that is the red nucleus. And the red nucleus is enveloped. Enveloped by what? Let's turn this over. Enveloped by what? The red nucleus is enveloped by what? Was it enveloped by the red nucleus? There's a halo around it. And that is what's that halo? Taylor? The dentato-rubro-thalamic fibers. Okay? So those fibers that are leaving the what? The dentate nucleus en route to where?
They're going to the VL of thalamus.
To the VL of thalamus. Very good. All right? Goes a little to VA2, but primarily to VL. Reasonable? Then what else do we want to put in here now? The oculomotor nucleus. Isn't that so? We want to put the oculomotor nucleus. Reasonable? And then somewhere about here we can put the what? The mesencephalic. Isn't that so? Around there. Okay, out here what are we going to put? These are the ascending pathways. Isn't that so? Very good. And then we divided up this into fifths. What is this? So if we put this thing through here, this imaginary line, then we said that is a tectum, and then the whole of that we said is a cerebral peduncle. Okay? And then having a part which is called the what? This part here which is called the
Tegmentum.
And tegmentum is associated with what? The ascending pathways. Tegmentum is associated with the ascending pathways. Then we have the substantia nigra, and then this last part here, which is the what? The crus cerebri. And that crus cerebri, we said we divide into fifths. So medial 1/5, an intermediate 3/5, and a lateral 1/5. Okay? Very good. So, where is Marcia? Very good. Good. So Marcia, what do we find in the middle 3/5?
Corticospinal and cortical.
Very good, excellent. So the cortico, spinal and cortico-bulbar. What do we find in the medial fifth? Yes. So that's very good. And in the lateral 1/5? Occipito, parieto, and temporo-pontine. Okay. All right. And then we find now the what? The third nerve. Isn't that so? Coming from here and going through there. Isn't that so? All right. We can have what is called a Weber's what? A Weber's syndrome. All right. In the Weber's syndrome, the Weber's syndrome is going to involve what? A portion of the, usually of the what? Of the cerebral peduncle. Isn't that so? But let's put in a better Weber's. Weber's, let's just go like this with the Weber's here. Okay, this will be more of a Weber's. Okay? Alright. Okay, so we're looking down on the brain. Reasonable? So this is the right side, isn't that so? We have the brain in front of us like this, okay? So say this is the right side, all right? Okay. Now, what is going to happen if we get a infract, okay? What is going to happen? So we get, this is a cerebrovascular accident that's going to happen to the cerebral peduncle. So what's going to be happening here now?
Ipsilateral oculomotor palsy.
Okay, all right. So even before that, so what about this patient? So what about this patient? What about that patient? So where's Dr. Cruikshank? Very good. So Dr. Cruikshank, what is going to happen to this patient here now? So, yeah, so by the way, we said that there's a third nerve lesion, but far more, very good, Misha, greetings. So far more than this third nerve lesion, so this is a, what kind of syndrome? Weber's. So we have a Weber's, we have a Benedict's, and we have a Parino, okay? So in this Weber's now, what is going to be more devastating? Dr. Cruikshank? What's going to be really devastating in this?
The dysfunction of your head and neck muscles, dysfunction of the lower limb muscles on your contralateral side.
On the contralateral side, isn't that so? So therefore we're looking at what? Maybe like a spastic, if it's a long time, then it's like a spastic paralysis. Okay, it's an upper motor neuron lesion. It's not a flaccid paralysis. Okay, so this is going to be an upper motor, that's a spastic paralysis. Reasonable? Or we're just going to look at a hemiplegia. Isn't that so? A hemiplegia of the whole what? Left side of the body, isn't that so? So the entire left side of the body. If we hit the right side, we're going, therefore the whole left side of the body will be affected. Isn't it so? From the face, is it from the face going right down? Well, it's going to involve our corticobulbar, isn't that so? So this is a corticobulbar, but it matters the involvement of the corticobulbar, okay? But definitely of the upper and the lower limb and the contralateral side of the body, isn't that so? All right, and then now we're going to affect now the third nerve. So what is going to be the effect now, Taylor?
Of the third nerve palsy?
Yes.
You would have mydriasis.
Mydriasis? Yes, mydriasis. What else will we have?
In the third nerve palsy, you would have ptosis.
Can the person lift the eyelid up, open the eyelid?
No.
So they will get a
Ptosis.
ptosis. All right. So we get what? How is the eyeball? When you
Eyeballs?
lift up the eyeball and you want to look at the
It
eyeball,
would be down and out.
down and out. All right. So they will have also what's called an external strabismus. Isn't that so? They would have a external strabismus, and they try to look out now. Then they would get diplopia. Okay. All right. So they're going to have a, because we have hit the third nerve, therefore we're going to have the eyeball going to be what? Abducted down and out. All right, but that would also constitute an external. You can have a medial strabismus or an external or strabismus, okay? And then there is mydriasis. And then there is ptosis, okay? All right, so we see all of those things. All right, what about the facial nerve? So we're going to also hit the corticobulbar tracts, isn't that so? So the corticobulbar are mixed up in here. So in a Weber syndrome, we may also hit the corticobulbar tracts. What do we know about the corticobulbar tracts? That they supply the nuclei on the opposite side. Reasonable? So they will be crossed. Okay? So they'll be crossed. So they're going to affect the facial nerve. They may affect the facial nerve. Reasonable? All right. So we may see a weakness of the muscles on the opposite side. Isn't that so? A weakness of the muscles on the opposite side. All right. Okay, what about the tongue? If you stick out the tongue, this tongue is going to,
Away from
the tongue deviates to the what? To the affected side. Therefore, to the left side is going to cross there, so we get the left. What about the uvula?
Oh, yes.
Uvula tends to go to the opposite side. Reasonable? All right. Okay, so we must think of all the effects of the corticobulbar. All right. No, we get something. No, the Benedict's, right? The Benedict's is sort of variably described. Some people have the Benedicts more just associated with the tegmental area, but the Benedicts may take in a Weber's together with the what? Going into the tegmentum. Okay? Alright, so if we really get deep in here, what are some of the effects that we're expecting to get now? So we're deep in here. So what are the effects what we're going to see with that patient now? So we're deep in here. We're more like going into the land of Benedicts. We've gone into the tegmentum. Alright? So not only is there a motor loss, right? So there's paralysis, okay? But then there is what? Lack of sensation, isn't that so? So there's a lack of sensation on the whole side of that body, right? Isn't that so? Because we're going to affect this whole what? Band in the tegmentum here. So we're going to affect the medial lemniscus, we're going to affect the spinal lemniscus, we're going to affect the trigeminal lemniscus. So if we knock out the sensory nucleus of the trigeminal nerve, right, therefore there's no sensation on that side of the face, no sensation on the body coming right down. Reasonable? Right? John Fowler will do a good examination. Even though the person, look, I can't, John says, I don't take your word for it. I have to do a what? Full and thorough examination. Reasonable? So John Fowler does his thorough examination. It's okay, Sean? Right. All right, he does the thorough examination. He's observed that there is. He said, but I told you, doctor. I said, no, I have to see for myself. Right? Reasonable? So there is what? Sensory loss together with motor. All right? Then now, what have we also affected? The red nucleus. Okay, so we've affected the red nucleus. And we've affected the what? The output of the neocerebellum. So we're therefore going to get paleocerebellar effects. Reasonable? Okay, and remember this is going to tend to cross from here you're going to get a little later down the decussation. So we'll see it on the opposite side. Reasonable? So when you hit the paleocerebellum, okay, so there's a man by the name of P. Alright, let's relax. So we see some orange pins here. Alright, some orange pins here. Alright, just want to tie up this neural, you see? Then we see some pins here. Alright, we see some pins there. Okay. And we see some pins over. I can't find any of my red pins. Okay. I think they're upstairs. Red ones. Any red ones? No, they must be all upstairs. Very good. Excellent, warm. Very good. Thank you very much. Okay, so there we see the pins here. Isn't that so? Alright. Okay. So therefore you're going to be knocking out the paleocerebellar output and the neocerebellum. Isn't that so? Alright, because we have hit the red nucleus and we have hit also the output around the that's the dentato-thalamic output. Okay, so when we hit those green pins, what will we observe? So that area of the cerebellum is hit. And then also we've hit the what? The substantia nigra. So we get a Parkinson's on that side, isn't that so? On that side we will get there a Parkinson's. Okay, so when we knock out the area with the green pins, what will happen? On the green pins. Alright, what happens with that area on the green pins? Dyskinesia. What the hell is that, man? Like go from a rumbar or something like that. Dyskinesia. What is this thing? No. So that area in green. Remember I said we have to tie up things, John? Okay. Alright, where's the forceps? So remember this is midline cerebellum, right, P? So that's the vermis, which is equal to the archicerebellum. Archicerebellum equals to what? The vestibulocerebellum, right? So the midline is vestibulocerebellum. So from now till you graduate, until you see your patients, midline is vestibulocerebellum. Then this area is the paleocerebellum or paravermal area, because that's the vermal area. So therefore this is the paravermal area, right? So that's paleocerebellum, which is also anterior cerebellum, which is also spinocerebellum, and then this is neocerebellum or pontocerebellum. Okay, why is it called pontocerebellum? Because it's getting primarily from the relay in the pons. Okay, spinocerebellum because it's getting primarily from the spinal cord through the spinocerebellar tract. Vestibulocerebellum because it's getting from the vestibular apparatus. So P, if you knock that area, okay, for one reason or another, what are going to be the effects?
The unconscious perception.
No, what are the effects on a patient? What will notice to the patient? What about what will happen? Remember that cerebellar lesions manifest themselves how? Ipsilaterally. Cerebellar lesions manifest themselves ipsilaterally. Okay? Alright. But these tracks are going to have to cross. Remember, from the red nucleus now, however they cross. Okay? So you're not knocking the cerebellum, but we're knocking the red nucleus. Okay? Remember, all the output from the, because deep inside the paleocerebellum are which nuclei? Globose and embelliform, which form a nucleus called the interposed nucleus, and the interposed nucleus feeds on to the red nucleus, goes over to the opposite side, isn't that so? Crosses through the decussation of the superior cerebellar peduncle to go to the red nucleus of the opposite side via the interposed rubral tract, and then the rubrospinal tract, as it forms, it crosses back. Reasonable? So all these things are ipsilateral. Okay? All right, just give a chance. So what we're expecting now are to affect things like posture. What are we going to affect? Patient has posture. Then muscle tone. Reasonable? And reflexes. What kind of reflex? Pendular reflex. So when you ask the patient to go like this, then we see one side just starting to drift. Okay? When you see one side starts to drift, so the muscles weaken very easily. So it's hypotonia, isn't that so? Hypotonia. So if we hit that part of the cerebellum, we're expecting to see hypotonia, asthenia. Asthenia is weakness of the muscle. Muscle loses its tone, reasonable. Posture is affected, and the reflexes are altered. We get what's called a pendular reflex. Isn't that so? All right. So that's the functions of the paleocerebellum. Reasonable. So that's what we expect to see. And also we have hit the what? The neocerebellum. Okay. If we hit the neocerebellum out here, then we're going to get what? Incoordination. Cerebellar. So we're going to get what? The synergy we're going to lose. So we're going to lose what? The fine coordinated movements. So for example, when you try to pick up an object, we're going to get an intentional tremor. Reasonable? The person will be normal like this, and Mr. Jones pick up his forceps. Reasonable? And he gets an intentional tremor, and he also is going to get what? Pass pointing, which is dysmetria. Reasonable? Okay, so we're going to be affecting these muscles. Any other muscles that we're affecting when we're over here? He's going to affect also the extraocular muscles. So he'll get nystagmus. Okay, so these cerebellar things will manifest themselves in a nystagmus. Is he going to be able to talk like this? No. Talking, coordination of muscles are not only coordination of this kind of movement, but coordination of the muscles of the larynx, etc., and the tongue. So he's going to get dysarthria. So he's not going to talk clearly. Reasonable? All right, so he's going to get dysarthria. Right? He's going to get nystagmus. He's going to get dysmetria. He's going to also, if you ask him to do rapid alternating movements, dysdiadochokinesia. Reasonable? So a lack of coordination. In this area here, we said this area is going to be having problems with muscle tone, weakness, dysmetria. Reasonable? That's that area. Okay? So what holds the head of the humerus in the glenoid cavity? What stabilizes the shoulder joint? So what stabilizes, Brandon, what stabilizes the shoulder joint? What's the factor? Because remember, the glenoid cavity is a shallow little thing, and the head of the humerus is a big structure. So it really, there's not like down here in the acetabulum, there's nothing to fit into. Reasonable? So what holds it in place? Brandon, as a man who knows his anatomy very well, man is going to carry a whole heap of anatomy up to the clinic, you know. You watch for him, Maddie, when you see him up here. Right? So what is holding the head of the humerus in? And that is the rotator cuff. Isn't that so? What really holds the head of the humerus in is the rotator cuff. So it's a tone in those muscles. So if you lose the tone in all of these muscles, then the head of the humerus wants to just fall out. Right? So the patient will come into the clinic with what's called a ragdoll appearance. Remember we've said that already? A ragdoll appearance. Because what's really holding the head of the humerus in is the pull of the muscles. Because when you really look at the joint like that, the head of the humerus is out here. And all the glenoid cavity is merely just a flat surface like this. So there's nothing really to hold it in other than the pull of the muscles of the rotator cuff. Now, just for fun, Tila, what muscles form the rotator cuff? Listen to me, right till you graduate, and when you go to the orthopedics, isn't that so, Dr. Cruikshank? Everything is rotator cuff. So there's people like Dr. Vaughan and Dr. Palmer and Dr. Raleigh, and there are a whole heap of names. These are all orthopedic people, and they're expecting you to arrive at the clinic, you know, full of anatomy. And when the man starts talking about the rotator cuff, we have to know about the rotator cuff. So what about the muscles of the rotator cuff now? Anteriorly, what muscle is there? Subscapularis. Above is a very important muscle. Supraspinatus. Then we get what? Infraspinatus. And then we get what? Teres minor. Reasonable? All of these are the muscles of the what? The rotator cuff. And they are onto the what? Onto the greater and the lesser tubercles of the what? Tuberosity of the humerus, and pull it and keep it in. Reasonable? They're there. So if the muscle tone is gone and the muscles become all hypertonia and asthenia, then the whole thing. So the patient walks in with a sort of a ragdoll appearance. Reasonable? Mr. Jones, hold your hand up like that, and you just see him drifting like that on one side. Reasonable? And he may have nystagmus. Reasonable? Mr. Jones, when you talk, he doesn't talk to you nice and fluently like reasonable, like how John Fowler talks, right? So all of these kind of things happen. Reasonable? And on top of that, we're going to affect third nerve. Reasonable? So the third nerve is also affected. Okay? Now, how do we differentiate a Horner's syndrome from a third nerve lesion? A Horner's syndrome from a third nerve lesion. How do we differentiate those things? A Horner's syndrome from a third nerve lesion. John Fowler, as a chief neurologist here. Right? How are we going to differentiate a Horner's syndrome from a third nerve lesion? Because both of them have a ptosis, isn't that so? Both of them have a ptosis. But remember, in one there is a meiosis, and in the other one there is a mydriasis. Reasonable? So we have, this is a meiosis, so we have a constricted pupil, okay? But the ptosis is different, okay? Because what muscle is involved? What muscle is involved now? There's a lady by the name of Addie. What muscle is involved? Right? What muscle is involved? Very good. The levator palpebrae superioris. Reasonable? All right? The levator palpebrae superioris. And that muscle is mixed. It is both smooth muscle and skeletal. The smooth part is known as whose muscle? Muller's muscle. Reasonable? And the smooth part is known, given by what? By sympathetic fibers. Reasonable? And the other part is by the third nerve. Okay? So, let me ask you a very quick question. How, when the third nerve is supplying that levator palpebrae superioris and the Muller's muscle, where are the sympathetics from? Where did that third nerve get the sympathetics from? Where did the third nerve get those sympathetics from? No, where did it meet to get it? Where did the third nerve meet to get those sympathetic fibers? Where did they meet? Probably. Indeed, we have to meet. We have to what?